Hello and welcome to the topic Approach to Cardiac Arrest in the Core Knowledge module. The American Heart Association has defined cardiac arrest as the abrupt loss of heart function in a person who may or may not have diagnosed heart disease. The time and mode of death are unexpected, and it occurs instantly or shortly after symptoms appear. Here we will be looking at what cardiac arrest is from a practical point of view. When any one of these four rhythms are recorded on a cardiac monitor or ECG in an unconscious patient, it is termed cardiac arrest. It simply means the heart has ceased to function or beat. Let's look at these four abnormal rhythms individually. The four rhythms are broadly divided into shockable and non-shockable rhythms. Always remember that shock is delivered to cardiac arrest patients when there is still electrical activity in the heart, causing erratic contraction of the ventricles. The shockable rhythms are pulseless ventricular tachycardia and ventricular fibrillation. Shockable rhythms are rhythms that are caused by an aberration in the electrical conduction system of the heart. Defibrillation or shock is provided then to reset the erratically beating heart. Non-shockable rhythms are pulseless electrical activity and asystole. Pulseless electrical activity is also known as electromechanical dissociation. Asystole happens when there is no rhythm at all to the heart. In pulseless ventricular tachycardia, the patient is pulseless and the ventricular contraction is so rapid that there is no time for the heart to refill, resulting in undetectable pulse. You will see broad QRS complexes, which is more than 200 milliseconds, regular contraction rate, usually between 150 to 250 beats per minute. It is usually difficult to see a separation between the QRS complexes and the T waves. Next is ventricular fibrillation. In ventricular fibrillation, the patient is found to be pulseless and there are chaotic, irregular deflections of varying amplitudes with no identifiable P, QRS, or T waves. The ventricular rate is usually between 150 to 500 beats per minute. So what do you do when you see these rhythms? Shock immediately. If there's no defibrillator which you can get access on time, begin chest compressions. The technique of providing shock will be taught in the lessons ABCs of cardiopulmonary resuscitation. Let's look at this flowchart, which is the cardiac arrest algorithm. Look at the flowchart in the red circle. Once shockable rhythms have been identified, shock should be delivered immediately. Then proceed with chest compressions for 2 minutes. While chest compressions are being delivered, get help from your colleagues to secure intravenous access. After 2 minutes, rhythm is checked on the monitor, and if it is still a shockable rhythm, go on with the next shock delivery. Intravenous adrenaline 1 mg is administered every 3 to 5 minutes. Now, let's look at non-shockable rhythms. The pulseless electrical activity or PEA. Sinus rhythm is seen in a pulseless unconscious patient. PEA is a clinical condition characterized by unresponsiveness and lack of a palpable pulse in the presence of organized cardiac electrical activity. Pulseless electrical activity has been previously referred to as electromechanical dissociation. And lastly, asystole. When you see a flat line on the cardiac monitor or ECG, which indicates the absence of electrical activity. So what do you do when you see these two rhythms instead? Remember that they are non-shockable rhythms, hence start CPR as soon as possible. Refer to the flowchart in the red circle here. While chest compressions are being delivered, get help from your colleagues to secure intravenous access. IV adrenaline 1 milligram is administered every 3 to 5 minutes. Your senior will consider placing an advanced airway, which is an endotracheal tube, to ensure oxygenation and ventilation are not disrupted. These are the famous 6 H's of pulseless electrical activity: hyperkalemia, hypoxia, hyperthermia, hydrogen excess or acidosis, hypovolemia, and hypoglycemia. And the 6 T's, which are tamponade, tension pneumothorax, thrombosis, pulmonary thrombosis and coronary thrombosis, toxins, and trauma. So ensure as the resuscitation process is ongoing, you are actively looking out for these 6 H and 6 T causes of pulseless electrical activity. This can be done by quick examination, lab tests, or point of care testing. This slide has a summary of the advanced learning tips you might need during your encounters with patients in cardiac arrest. Take note of the CPR quality that needs to be delivered, the drug therapy that needs to be administered, the advanced airways that can be provided for the patient in order not to disrupt the oxygenation and ventilation, the return of spontaneous circulation and what to do next, the shock energy that needs to be delivered in different situations, and finally, the reversible causes for cardiac arrest. So let's recap. We have got the 4 rhythms, which are broadly divided into shockable and non-shockable rhythms. Always remember that shock is delivered to cardiac arrest patients when there is still electrical activity in the heart causing erratic contraction of the ventricles, and these are pulseless ventricular tachycardia and ventricular fibrillation. However, in pulseless electrical activity and asystole, there is no cardiac contraction, hence you begin CPR. We have come to the end of this topic. Please find and click on the link to open the Advanced Cardiac Life Support Guidelines for further reference. Thank you.